to welcome you to the geko-sponsored symposium, where I'm very pleased to be joined by Dr. Indira Natarajan, a consultant stroke physician. Dr. Indira has held leadership positions within stroke care, both regionally and nationally, and has always been a champion and ambassador for stroke victims. He won the Health and Social Awards for Stroke Services and the Healthcare Pioneers Award. It is my pleasure to introduce and pass over to Dr. Indira. Thank you.
Thanks, Joe. And you can see the slides. Is that right, Joe?
I can, yes. Thank you.
Yeah, thanks for the introduction, and thanks for this opportunity to be a part of Thrombosis UK. I'm a stroke consultant in Royal Stoke Hospital in Stoke-on-Trent, and I'm going to talk on VTE prevention in stroke patients. And stroke patients pose a challenge because it is a leading cause of adult disability in the UK. When you have a stroke, there is a high chance that you're going to be mobile for a period of time while you get better. And there is a possibility of mortality as well. So VTE is one of the challenges as a post-stroke complication. So just to give you a flavor of how big the burden is, this is a slightly older slide. Probably now around 130,000 people are admitted to the hospital with a stroke each year. And around 55,000 of them will be unable to walk as soon as they are admitted until they are discharged or going into ongoing rehab. Approximately 25% will die within 6 months. In our unit and across the UK, the split is around 85% of them are ischemic strokes and 15% are hemorrhagic strokes. So what is the VTE burden? And from the data from SSNAP is an ongoing audit database. We just get a live data every year, and we know that approximately 20% of these 55,000 immobile stroke patients develop DVT, and 5% of them will develop pulmonary embolism. And I mean, this is the source we chose triad, which clearly shows why do we develop thrombosis as a VTE. It's a combination of vessel wall injury, stasis, and hypercoagulability. And this is what happens in stroke. We got temporary or permanent loss of limb movement. People can be prolongedly immobile. Because they are immobile, they get disuse wasting of the perotic limb, so loss of calf muscle pump activation and function, and this puts them at increased risk of stasis. So that is why VT is an issue in patients who have had a stroke. So if you are a practicing stroke person in the last 10 years, these were the different sort of tools that we had to prevent VTE. So we've had graduated compression stockings, then came intermittent pneumatic compression devices, and there is a debate about anticoagulants, when should we use, when we should not use, and what is the guidelines. I'll take you through that, and early ambulation. Apart from this, what we should not forget is good stroke unit care, good hydration, aspirin, early mobilization, starting them with nutrition earlier also has a huge role in preventing VT. So we can't forget about our day-to-day nursing and a stroke unit care. On top of that, these were the options that were available. So just about the stockings, probably around until 10 years ago, if I remember right, we were using graduated compression stockings. There used to be units where we used to use below knee stockings and above knee stockings. And the day CLOTS 1 and CLOTS 2 trials were published, stockings were out of the stroke units. There was no benefit of stockings in preventing symptomatic VTEs. So then we had to go on to IPCs after the CLOT 3 trial. I'll just tell you about the CLOT 3 trial shortly. And even with IPCs, which are recommended by the NICE guidelines, the RCP guidelines, the European Stroke guidelines, and the American Heart Association guidelines, IPCs, the first line or standard of care. But even with that, there's only a 70% compliance. So there were another 30% of patients who couldn't fit into what was recommended by guidelines. So the only other alternative was, is it drugs that we can go for, like low molecular weight heparin or heparinoids? Again, it's difficult because the guideline says unpredictable bleeding risk, and we do not know which are the patients who are not going to bleed and who are the patients who are going to develop VTE. So drugs are quite difficult to place in our VTE standard pathway. But I still notice that this is widely practiced in America and Europe, where once for a couple of days they use the standard of care like the IPC, and then a lot of units switch on to drugs against what the guidelines recommend. So, what did the CLOTS 3 study show us? And this was a big trial, the RCT at that time, led by Martin Dennis's team and Edinburgh Neurosciences team. It was a RCT. They assessed patients with the IPC versus no IPC in acute stroke patient. They measured VT incident in 30 days. And the results showed that 30% reduction in DVT and 14% improved in overall survival in 6 months. As a result of CLOT 3, as I said, there was a big change in the guidelines. All international guidelines now recommend IPC and advised against compression stockings and heparin in immobilized patients. So this was a slide which I've taken from the CLOTS 3. And if you look at the bottom, you know that the VT incidence without IPC was 8.7%, but with IPC it reduced to 6.6%. And the issues was adherence occurred in a less than third of a patient, because skin breaks occurred more frequently in IPC group and then no IPC group. And IPC has got a contraindications as well as intolerance, like patients who got ulcers, who got peripheral edema, who got vascular disease like peripheral vascular disease. Those are the group of patients where you can't apply the standard IPC. So uh, in our hospital at Royal Stoke, we did start IPC as a first line for all acute stroke patients in the first 30 days of admission. We risk assess them on day 14 to consider if prophylactic low molecular weight needs to be added. In most cases, we continue VT prophylaxis until the patient becomes fully ambulatory or they're getting discharged. Once on discharged, then we stop all VT prophylaxis. So what we started to recognize that we were aware not all patients can tolerate IPC. And we wanted to see that, is there anything that else we can do to find out whether there is any alternative antistasis intervention where IPC cannot be prescribed. And we do not want to take the risk of going through the drug route, where we clearly know that risks of symptomatic intracranial hemorrhages are high, and we do not have a mechanism in finding out which are the groups of patients who are safe to go on to low molecular weight heparin or heparinoids. So we were a team eager to try new treatments of care to challenge the status quo for better patient outcomes. So at that time, we were introduced to a neuromuscular electrostimulation device, which was reviewed by NICE, and it said that you can't use that as standard of care, but can be used when standard of care is impractical or contraindicated. So this led us to think, right, okay, what does that mean to our unit? We wanted to see, first of all, we wanted to quantify the level of unmet need, and that was clearly 30% of patients who couldn't tolerate standard of care. We wanted to evaluate the device along with IPC, and we wanted to see whether it is reducing VTE at the 90-day follow-up, or whether we were causing more harm on this group who couldn't tolerate. A new change in NHS is very, very complex. It develops a case of investing in a new method or equipment. A number of considerations must be taken into account, and most importantly, patient safety, because we do not want to go and solve the unmet need at the same time causing harm to the patient. So patient safety was paramount. So we piloted it to make sure it is safe on the patients who couldn't tolerate it before we tried to do a real world audit. So we did the audit, and with 1,000 patients between November 2016 and March 2018. It was an 18 months to complete. And before we implemented the audit, unlike the drug, where if you give a drug, and if it is signed by the nurse or any sort of healthcare professional who's giving the drug, we know the drug is into the system. Whereas where any external devices that are used to prevent antistasis, like IPC or mechanical device, it has to be on the patient's legs 24 hours. Only then you are certain that you're preventing stasis. There's no point in wearing for a couple of hours and then switching it off. So we had to make sure that we train all the nurses to look after the IPCs and the devices to be fitted into the patient's legs. So we had to make sure that all the shifts are covered with a champion who make a mandatory patient check to make sure that it is correctly fitted and they're working. And we also had to monitor patient compliance. If these are not adhered, then you can't go for any sort of external devices. And once you're going into an observational audit of your practice, it needs lots of governance and checks. So we need to go through our divisional governance board. We had to go through a VT steering committee. We had to have a clear inclusion exclusion criteria. We need to get the hospital pharmacy on board. And also we had to, just like the drugs are prescribed, these IPCs and the neuromuscular electrical stimulation devices should be prescribed on a drug chart. So we had to get it through the hospital system so that we have a separate place to prescribe these. This took several months because we had to get the stocks, we had to get all the tick boxes before we start the project. And we also had to create a database, which was a simple Excel database, incorporating all the data that we got. So where did we use these patients? The neuromuscular electrical stimulation device. Patients unable to mobilize independently were prescribed IPC alongside the standard of care. As I said, it is paramount that we need to make sure that top quality nursing care was already in practice. Hydration, early mobilization, aspirin were indicated. This was we need to make sure that all the patients adhered to the VTE guidelines. Patients who could not be prescribed IPC due to intolerance or skin irritation were switched to the neuromuscular electrical stimulation device. And there were another group where we started on with the IPC, but they were not able to tolerate it, were switched on to the neuromuscular electrical stimulation device as a second intervention. And we regularly followed up these patients up to 90 days, even if they were discharged or moved to another rehab unit, to look for what was the incidence of VTE in this group of patients. So this was our audit results. So of the first 1,000 patients, at present we have data for 2,000, but this was the results of 1,000 patients. You notice that 688 of the 1,000 patients needed intervention. 203 patients were clearly straight away could not be prescribed standard of care, that was the IPC, or they were not tolerant to it. And this group represented around 30%. So this was a big learning curve, that our data matched with what they found on clots. So if you have a unit which just goes on standard of care, there'll be, for every 100 patients, there'll be 30 patients where your standard of care can't be met. So what happens to these 30 patients? Do you just go on to a drug prophylaxis where the risks of intracranial hemorrhages are high, or you look for something alternative? And that's where we felt that this was in the right place for an alternative to IPC and preventing us to go into a drug therapy. The VT incidence in 90 days was 2.5% on IPC alone, and we didn't have any VTs in the neuromuscular electrical stimulation device. However, in our second 2,000 patients, there was a small, when we had the data done for 2,000 patients, there was a small group of patients who did develop VT as well. The NMS, the device was quite well tolerated. There was 90% adherence compared to 78%. And it was worn on both legs for 24 hours per day, as per our the champions who were looking after these patients over a period of time. And the average duration of use was between 5 to 9. That was the average days, and because most of the patients were discharged during this time, and the maximum duration that the patient wore was 30 days. After 30 days, we didn't go on to any sort of mechanical intervention. So this real world audit data changed our clinical practice in our stroke unit. And now the neuromuscular electrical stimulation device is now routine for our unmet need VT prophylaxis, meaning that for every 100 patients admitted to the stroke unit, we have an option of VT prevention before we go on to drug therapy or no therapy. And following the use of the device into our armory, we had 46% reduction in VTE in our unit compared to the time before we started using this. At present, if you walk into our unit, we clearly know who's on IPC, who's on this device, and which is a small group of patients who are on drug treatment, which is a very, very small group. And I can't emphasize the importance of surveillance. Even if you're not going to use, neuromuscular electrical stimulation and just standard of care, what NICE and all the guidelines fail to recommend is you can't just assume that prescribing IPC will prevent VTE. It has to be worn around the patient's legs. And if you had tried IPC, it has to make sure that there's no gap between the sleeves and the leg. Even if you have a gap so that you can insert your finger breadth, that means that is not effective. It has to be tightly wrapped around the calves so that the pumping action prevents venous stasis. Assuming that you're using a standard of care is not is enough, you need to make sure that you have periodic checks that the devices, particularly in nights when people are sleeping, there's a high risk that these IPCs can fall out, so as the NMES. So you need to have mechanisms in place in your unit to make sure that these are worn. And our real world audit data has influenced other NHS stroke units to qualify their unmet need and to embrace innovation. And all centers whom we've spoken to across the country where they come and spoken to us clearly understand that there are around 30% of patients who can't tolerate standard of care. As I said, that we've now set the stands at 2,000 patients, and we are writing up a manuscript for publication, which will be coming out quite soon. So we wanted to now move on to the next step. Now we know that the real world data, we know that NICE has given the tag that it is safe, but we can't influence a change to the guidelines until we have a head-to-head multi-center RCT. So we needed to see whether the neuromuscular electrical stimulation device could be more effective than IPC in preventing post-stroke VTE rather than used for unmet need alone. So we want to see how we can get that question answered. So now we've got the NIHR grant for a head-to-head multi-center RCT, which is now going to be underway across England. Site recruitment is commenced. This study is run jointly by the stroke survivors, clinical researchers, stroke physicians, academic staff at Keele University, and the manufacturers. So the primary objective is for a head-to-head on the device versus IPC. We are going to look at the VTE outcomes in 1,200 patients. Secondary objectives are safety and patient tolerance, survival, functional outcome, and quality of life, health, economic, and environmental impact as well. The study design, it's a prospective multi-center RCT. At least 10 study sites in England are proposed. We're planning to enroll 1,200 patients, 600 in each of the arm. The treatment duration is going to be 30 days or until the patient is independently mobile discharged into the community, whichever is the earliest. Follow-up duration is 3 months. It's a randomization, 1-to-1. So after randomization, we'll know which arm the patient is going, either into the neuromuscular stimulation or the IPC arm. And obviously, we want to make sure that all the patients who are coming into the stroke unit have got high level of evidence for VTE prevention. We are aligning ourselves to the NICE guidelines, and by sharing this experience, we hope that other units will embrace this, and hopefully in the future the RCT will give us the answer, and that will probably change the outlook of management of VTE prophylaxis in post-stroke patients in the future. And thank you very much for your attention.
Thank you very much, Dr. Indira. That was very interesting. And And again, please, in the audience, if you have any questions, do put them into the Q&A or the chat. The Q&A is probably easier for me to manage. So if you do that, that would be helpful. We've certainly had somebody comment that was awesome. So thank you. We do have some questions. So just taking you back to the starter when you first did this, when you're introducing anything new and a device in these very unwell patients, what sort of training did you have to prepare to both prepare staff to use it, but also to build confidence in everybody? Was that straightforward?
Yeah, that's right. So when we looked, even before going before the unmet need, and as I said, the guidelines only says you need to use IPC, but the guidelines doesn't emphasize that the IPC should be around the patient's legs for 24-hour period. As I said, unlike drug, you can't just prescribe and think that the patients are going to have it. So somebody has to monitor that it has to be around the patient's legs for the 24 hours to prevent venous stasis. And none of the units had that mechanism in place. We clearly knew that when I come for a ward round on the morning, I'll see them dangling down the patient's bed. Somebody's already pulled it out during the night. So these patients have had, we are not entirely sure how long they have not had the devices around the legs. So that was the first thing. We wanted to make sure that we do the standard of care properly. So we had to make sure that we train all the nurses. So we have a person named to make sure that when they come on shift, and every shift, that somebody goes around all the patients to see that the the standard of care, even if it's IPC, it's around the patient and it's working. So that's the first thing that we wanted. That's the first change, even before we went for the unmet need. So then we knew that there is certainly going to be a 30% population in our cohort that they're not going to tolerate the IPC. So what is the next thing? So we're going to introduce another device rather than going on to drug therapy. So we said that we will train them across the both areas to look for how IPCs are tolerated. If they're not tolerated, then these champions will come and say, this patient is consistently not tolerating IPC. Can we go for an alternative? So then we trained how to place these mechanical devices. There is a slight technical way we need to place, because once you put them onto the legs, we need to make sure that it's tolerated. It is creating a gentle jerky movement so that the calf muscles are pumped. And again, we wanted to make sure that that doesn't fall out as well. So there was a huge investment in training. But once you train the first cohort, then it's a rolling training program. So then these people will start training the next cohort, and we run stroke schools 3 times a year. And this was an integral part of our training. And I have to emphasize, unless until the training in place, you can't assume that your standard of care or anything new you're going to go is to work, unlike drugs.
I think this next question might come into another question that's also been asked. So you mentioned in your presentation, you obviously had to go to various boards within your hospital and committees and bring them on board. And somebody has said, they have stroke patients in acute medicine units which lack IPCs and trained nurses to use these. Any solution, as we do not have NMES devices. Now, what did you find really were game changers to make people come on board with this, and what evidence or support did you present to make them work?
Yeah, I think before we wanted to implement, we went to the divisional governance board with a nice tag saying that these devices had the nice tag and there was a quality check in place, and we are not going to use this as the first line. So even before we introduced it as a real world data, we said we will pilot it for 100 patients to make sure safety is paramount, because we wanted to make sure that what we are doing is not causing any harm. So when we had the pilot, we took the data back to the governance team to say, right, we piloted it. It is a safe device and it's not causing any harm. And and we had to provide any sort of adverse reactions, if there was any intolerance, any allergic reactions, or any harm that's come to the patient. So we had to go through all the safety checks. Then we had to get the pharmacy on board, and we had a regular sort of 3-monthly update to the governance team to make sure that the safety is paramount, we're not causing any harm, any untoward effects are reported. And once we got that, we got it prescribed on the drug chart. And after the first data, we were very convinced that this was an alternative, and now it's a standard practice. to the question of patients outside of the stroke unit, very difficult. That means these patients are sadly are left out because it's very, very difficult to just go and train an entire team when the patients are outside the unit. We have managed to train intensive care because a very small group of patients after stroke with big bleeds or a big ischemic stroke who go neurosurgical intervention go to intensive care. We go in and we've trained all the intensive care staff. So post-stroke patients in intensive care either get IPC or a neuromuscular stimulation device, but it's very difficult to roll it out across the medical units where patients are paralyzed for any reason, not only strokes, for a variety of spinal cord conditions or road traffic accidents. It's very difficult to adapt it across all neurosciences units.
Thank you. Some practical questions again, really on something I've heard many times. What was your criteria as to mobilization? When do you think somebody is mobile and doesn't need this sort of extra intervention or is immobile?
Right. Okay. Stroke care is advanced in the last 10 years with hyperacute interventions like thrombolysis, thrombectomy, early identification of these patients. A lot of patients are now beginning to walk out of hospital. But still, as I said from our data, there are around 55,000 to 60,000 patients out of the 120,000 patients are mobile, at least for the first, immobile or partially mobile for the first week. So anybody who is not able to walk independently unaided are classified immobile. So even if they're partially weight bearing, are struggling to transfer from a bed to chair or needing assistance of one or two, or are technically mobile because they're spending most of the time in chair or bed. And once in the first phase, deconditioning happens, and they have disuse wasting, and that's the time when stasis develops. So unless they are independently walking out either to the toilet or doing their own shower, that group of patients are high risk of VTE formation. So that's a group that we are targeting.
Okay, thank you. Someone's praised your presentation and asked, what are the main contraindications for the neuromuscular devices that you're aware of, or that you use?
The contraindications are very, very limited. There are so the initially we were very worried about, because it's a battery operated device where it just inflicts some sort of movements to the calf. We thought that might be painful and some patients may tolerate, but for the first couple of hours they find it discomfort, but then patients get used to it and they are even still able to sleep with it. The only contraindication is they use a gel to adhere to the skin. Some people develop contact dermatitis or develop itching, or some group of patients, don't like anything on the feet while they are sleeping. So that's an absolute contraindication. It's patient's choice. If the patient is not able to adhere to it, we don't force it. But that's a very, very small group of patients, and compliance was around 90% compared to 70% with the IPC arm. That was our real world data.
And a comment on this question, which I think the person is alluding to, saying, how did you select 14 days to review VT risk? And do you, as he's suggesting, or that person rather is suggesting, that some stroke clinicians might use drugs earlier if they're at high risk, assessing the benefits and bleeds? What's your sort of opinion really with this?
Right. I think that's a very interesting question. Again, if you look at the guidelines, right, the guidelines clearly says that drug therapy is absolutely contraindicated, right? Because the risks of symptomatic intracranial and extracranial hemorrhages are very high in the drug group, right? So if you travel across the country, or if you do even a survey, which we did, there are some stroke units where, because of the implementation process and because of they're not able to train and they are aware that IPZs are not tolerated, they want to have a day fixed. They think, all right, we will stick to guidelines for X number of days, and then we'll go on to alternatives like drug therapy. And majority of the units stick to the standard of care for 48 to 72 hours. and and this is not scientifically done. They just think the risk of symptomatic intracranial hemorrhages are within the first week or within the first 72 hours, and then that gradually weans away. But that's not what the guidelines say. So before we had the unmet need, we picked up the 14 days as that's the time we thought was the safest time to go for alternative to standard of care. But again, it was we're going against guidelines. So that was the reason why we had the 14 days. But a lot of units, I mean, even in if you go around Europe or in America, where we went a lot, visited a lot of stroke units. The ESO guideline states IPC and not for drug therapy, and the AHA also says. But as I said, probably they're not able to train the staff and they're not able to adhere to the standard of care. They quickly switch on to drug therapy, and their cutoff is 72 hours down the line whenever they feel comfortable.
Another question, we've got lots of them. So do they need to be removed when moving, such as if they're undergoing physiotherapy or
No.
anything like that?
IPC, yes, that's the downside of things, right? So I'm not sure how many people have, I mean, you'll have seen IPCs. It's like wearing batting pads before you're going out for a cricket match. It's two things. It's attached to a machine which pumps it keeps the compression. So it's a deterrent. As soon as you go around, if you have IV fluids, you have an NG tube, and you have an IPC, it looks like patients is attached to a lot of things. And then so the site looks as if this patient is, in fact, they might be moving their arms and legs, but the moment you go and see somebody attached, and so first thing we do in our ward round is detach patients to catheters, to fluids, to the and make them as euvolemic or physiological as process. The moment they sit out, that's a very starting sign that they are on their way to recovery. And a lot of physiotherapists or occupational therapists will take a patient out for a therapy, come back, and it might take a couple of hours before the IPC is put back. So that's another sort of major disadvantage, because you're again forming stasis during the time and they're not attached. Whereas with the neuromuscular stimulation device, they can carry on walking um, while a therapy is going on. So that's one of the other benefits.
Any tips on how you manage when bank staff join a ward and the training?
Yeah, it is difficult. That's a very, very practical question. But that's the reason why when we do the rotors and when we have shifts, we will only rely on the champions being people who have already been trained. It's very difficult to train ad hoc bank shifts. If you know that this particular bank shift person is going to be there, we run a short sort of induction in our unit. If we know that they're going to be for a month and they're going to regularly come to the stroke unit, that's quite easy group to train. But if you're coming as an ad hoc, it's very difficult.
Okay, thank you. And I think the last question I can see is, you've mentioned about this new research project which is being undertaken, and the number of patients you hope to enroll on this. Anybody listening now, are they able to join? How could they go about doing that?
Yes, if they want to send an expression of interest to my email, then I can put their team in touch with the research collaborators who are based in Keele University in my unit, and we will be able to talk to them. So if any unit or anybody who's interested can just email me.
Perfect. And if anybody doesn't have your email, if they email through the platform which comes into me, I will send it on to you as well.
Please.
So do find a way, but email in, because the important thing is to recruit for this trial.
That's very important.
Yes. We have got another question. So how often do you need to change the device, and can they be reused, or how do you need to dispose of them?
Right. Okay. That's very, very important practical question. The device only has it's battery operated. The lifetime of the battery is 36 hours according to the manufacturer, but we replace the device every 24 hours. So when they have the wash that following day and they get ready, we take off the old device and put the new device. And because it's got a battery operated device, the NHS has got a way in disposing. It's not the normal sharps box. It's a separate box that these go in, and there is training and education to do that, and it's disposed in a very, very safe way. So it's not an issue, but it has to be changed every 24 hours.
Okay, thank you. And do you use 2 per patient? Is that right? 1 per leg?
1 per leg, yes.
Yeah. Are they always on the leg? Are they ever on the other limbs or?
No, it's only on the legs, and it has to be on the fibula head because that's the place where one of the nerves called the common peroneal nerve runs, and this device stimulates the nerve to prevent the flexion and dorsiflexion movement, and thereby pumping the calf muscle to prevent stasis. So it can be only worn on the fibula heads.
Thank you so much. I think we've exhausted, maybe, exhausted most of the questions. There is a final one about the cost per unit, but I guess that would be local, but I don't know about that. So I'll pass that to you. Are you able to answer that? I'm not sure.
It's difficult because we do it comes through purchasing through the procurement. So it depends on, if you block purchase through procurement, then they will get a sort of a discount. So that has to be negotiated with the manufacturers.
Okay, thank you. Thank you so much. Another really interesting talk and many questions and discussion. Thank you. And I look forward to hearing more in the future about the research as well, which is really good.
Absolutely. Thanks for the opportunity, Joe, and I hope it was useful.
A pleasure.